All right. Thank you guys so much. Thank you for making time out of your busy schedule to talk about colorectal cancer. I'm hoping that this will be interactive and I'll try to look for any hand raisings, but if you guys have a question and I don't see your hand, I apologize. Please just go ahead and unmute yourself and jump right in because I want to make sure that you have a chance to ask questions if something's not clear. So I am going to attempt to share my screen here. We'll try to get it right this time. And we'll get started. Is everyone seeing my screen okay? All right, I'm not hearing anyone yelp no, so actually it doesn't look like that has happened. So let me try again. Kaylee, if I could ask you to unmute yourself and let me know if I've got this screen sharing correct.
We can see it.
Okay, great. All right. So today we're going to discuss some risk reduction techniques, or at least what we know about ways to reduce your risk to colon cancer, the different screening methods that we have, and also treatment options if we have time. But I really do want to make sure that there's time for questions. So please, everybody, feel free to jump in. By way of an outline, we'll go over some statistics and facts, some modifiable risk factors that we know about. And like I said, the data is not always clear. So I'm hoping to present an honest appraisal of what is known so that you guys can make some informed decisions. But there will also be a real bottom line recommendation, which hopefully will be helpful. And this does dovetail very nicely with Nutrition Month because as you can imagine, everything that we take into our bodies through our mouth has to pass through our colon. So that's definitely a key component for some of the things that we think are risk factors for colon cancer. As I mentioned, there are a lot of options for screening, and I'll say it here and I'll say it again at the end. The most important screening test or the best screening test is the one that you're willing to get done. Colon cancer is the one cancer that we can actually prevent by doing appropriate screening in most cases. So it's something I feel very passionately about and that I hope to encourage everyone to take that opportunity and pick the screening test that's right for them. And then, as I mentioned, if heaven forbid you're ever diagnosed with colon cancer or have a family member, we'll do just a very short description of what types of treatments and the results from those treatments that you can expect. So in terms of good news, this is sort of good news, good news in terms of cancer in general across the United States. The death rate from cancer has dropped from its peak in 1991 by 27%, and that actually adds up to over 2.6 million deaths that have been avoided. So 2.6 million mothers, sisters, uncles, aunts, fathers that are alive today because of increased screening, because of improved survival, and because of new treatments and research. Having said that, we lost just over 600,000 people in 2019 alone to cancer. So we certainly have not won the battle. We've just started to win the battle. And that adds up to 4,800 new cancer cases diagnosed daily in the United States. And it means that cancer is actually the second leading cause of death in the United States in most years. Cancer death rate did decrease by 1.4% per year in women and 1.8% in year for men. So it's not just the 90s that we started doing better. We're continuing to decrease our death rates with improved treatments and research. So that's the good news, the bad news, and the good news. In terms of colon cancer, it is currently the third most commonly diagnosed cancer in men and women in the United States, and it's the third most common cause of cancer-related death. Unfortunately, despite the fact that rates overall are decreasing, rates in younger people, younger than 55, have actually increased by 2% per year since 1995, and we do not know why. And that actually plays into a change in the screening recommendations that might surprise some people on the call. We're on track to have, unfortunately, about 150,000 new diagnoses of colon cancer in the United States in 2021, and it's estimated that 53,000 of those people will die of that disease. The lifetime risk is about 1 in 23 for men and about 1 in 25 for women. In Oklahoma, it's going to be about 2,000 people that are diagnosed this year, and colon cancer results specifically in about it's responsible for about 8% of all new cancer diagnoses in Oklahoma. And I'm going to talk through some ways that we can reduce risk, what the evidence is behind it, and it falls into some categories on this outline. So I just thought I would sort of frame the discussion in that way. There's some pretty solid evidence for things not to do, and I'm sure this will not come as a surprise that smoking is one of them. So things not to do or to try to stop. There's some really confusing and mixed data about the relationship between weight and colorectal cancer that I'll do my best to summarize. There is good data supporting exercise, and there's also some questions that we still have to answer about exercise. And then there's some mixed and usually confusing evidence about food and supplement choices that we can make to try and reduce our risk, and then some support for things like aspirin and calcium. As I mentioned, I promise I will give you a bottom line slide on all of this. In terms of modifiable risk factors, we know that smoking and alcohol are associated with a lot of cancers, and specifically they are associated with colorectal cancer risk. We know that a history of smoking or a prolonged history of smoking does result in an increase of about 25% for a risk of colon cancer, and that's about 10 packs per year or 10 pack years. So that's about a pack a day for 10 years on average. And we know that that seems to increase the risk of rectal cancer more than it does for colon cancer, but we don't really know why. Alcohol does increase your risk. The top study found a 24% increased risk if you compare in men, if you compare men who drink 2 to 3 drinks a day versus less than 1 drink a day on average. And for some reason, the risk is smaller in women, and there is a lot of differences between how men and women both are at risk for colon cancer and also their success rates for treatment that are a subject of a lot of investigation going forward because we don't understand why there's such a difference. Still, we know that there's a 7% increased risk overall for even 1 drink a day in both sexes. And it's a 38% increased risk for 5 drinks and 82% for 10 drinks a day. So there is a dose response. And if you can minimize your alcohol, keep it to less than an average of 1 drink a day. And obviously, I'm going to recommend that you not smoke. That's what it will do for you in terms of decreasing your risk for colorectal cancer. Weight is a super complicated topic with colon cancer. When I was in medical school, we were taught that colon cancer was associated with being overweight. And it turns out, of course, that it is a lot more complicated than that. So the slide that you're seeing on the left is a compilation of multiple different studies. It's a meta-analysis of I didn't even add up how many studies are in this meta-analysis. And they looked at the risk of death at any time point as related to weight gain from people that are in their 20s to 50s. And it's if you see all of these studies fall to the right side of this solid vertical line, and that solid vertical line represents a case where there's neither increased risk nor decreased risk. So if you're to the right of that line, it means that it indicates increased risk. And when they summed up all these studies, they do find a slight increase in risk of death from colorectal cancer among patients who gain weight between the ages of 20 and 50. What is even more interesting is when we looked at other studies where they looked at patients who gained weight from their 50s on, that increased risk seems to actually go away or is at least decreased. So it's a complicated relationship. There are a lot of differences between the sexes also that I won't go into, but it does suggest that attempting to not gain, at least the cutoff for most of these studies was about 11 pounds. So attempting to minimize that 11-pound weight gain between 20 to 50 is probably your best bet in terms of being able to modify your risk factors for colon cancer in relation to weight. As I mentioned, the cutoff is about 11 pounds, and each 11 pounds that are gained results in about a 3% increased risk. And it does seem to affect men more than women. And it also seems to be more important where the weight is on your body. So that apple versus pear comparison is important in colon cancer risk as well. And as in heart disease and other cancers, unfortunately, the increased weight around the waist is more risky than increased weight below the waist. Exercise. It's harder to recommend that people lose weight because that's obviously a complicated topic. And I don't think we have a great understanding of how to help people do that and terribly effectively. But exercise is something that all of us can do in one way or another. And so it is one of my favorite recommendations to give because it's achievable. And there is over 20 studies that show that when we combined all the studies, like I did in that previous slide, when you combine over 20 studies looking at the risk of colon cancer and exercise, we find a 27% decreased risk when you compare the most active patients to the least active. Most of these studies are looking at aerobic activity, and we don't know how much exercise is necessary. This is just a comparison between your most active and your least active. We also don't know what kind of a frequency, but I will give you a concrete recommendation. So weight gain is to be avoided if you can do it, and exercise is a pretty clear win-win, I think, for a lot of different disease processes, but specifically colon cancer. Dietary restrictions. This was actually a super fun part of the talk to kind of look into, because there are hundreds and hundreds of studies on dietary risk and modification risk factors for colon cancer. And the results are pretty confusing, honestly, but there are a few common themes that I'm trying to summarize here. We do know that a lot of red meat in your diet is associated with a modest increased risk of about 17%. And by a lot of meat, I mean on average more than 3.5 ounces a day. And so that palm over here, I'm hoping people can see the mouse. This is, if you take about a 1/2-inch steak, this size is 3.5 ounces. So the recommendation in terms of risk reducing for colon cancer and red meat is to stay under that amount on a daily basis if you can. The data is actually a lot stronger for reducing your risk of colon cancer by decreasing your consumption of processed meats. So things that have undergone fermentation, salting, preservation, curing, smoking, all of the things that make things super yummy, unfortunately seem to transform some of the chemicals within the meat and increase your risk. And so the dose that we recommend people stay under based on for colon cancer risk reduction is about 1.75 ounces a day, or about half of that palm-sized serving that I showed you for the meat. And it actually adds up to being 2 of these Energizer batteries, just to give you an idea. The relationship between fat and colon cancer risk is a lot less clear. There have been some very good studies with very tight control of fat consumption and diet reporting, and they haven't been able to show a benefit for decreasing your fat consumption by 10% per day over a mean of 8 years, with no difference in women, a slight potential difference in men. And when they combined a bunch of studies together in one of those meta-analyses, they didn't find any benefit for reducing fat consumption for colon cancer. Now, there's obviously some other disease processes where fat has a stronger relationship to the disease. So I'm not suggesting that everyone should go out and eat a ton of butter. But in terms of reducing your risk for colon cancer, it's not entirely clear that reducing your fat intake is beneficial. Fiber and exercise are probably my 2 favorite recommendations. In the United States, unfortunately, we should be getting about 25 to 30 grams of fiber a day in our diet, and that's soluble and insoluble fiber. But unfortunately, we're averaging about 15 grams a day. So we're not doing great in the fiber department. And fiber really does decrease your risk of developing polyps, as you can see on this top bullet. So 10 grams a day of whole grain fiber, 10% decreased risk of polyps. And polyps are essentially baby colon cancers. In a lot of cases, they can turn into a colon cancer, which is why screening works, because we can remove them when they're polyps before they can become a cancer. This is whole grain fiber risk reduction, but fiber from fruit and vegetables and legumes has also been shown to be productive, just not quite as high a magnitude as the whole grain fiber for colon prevention. Risk reduction for increasing your intake of fruits and vegetables can be as high as 26% if you increase fruit and vegetable consumption for a total of about 4 apples versus a half an apple. And I'm not suggesting you only eat apples, but you can imagine the amount that you would need to get 800 grams of some fruit and vegetable a day. And that has been shown to reduce risk quite significantly. There have been a few studies that didn't show a great benefit, but again, I think fruits and vegetables are something that is achievable and associated with a lot of other good. Supplements are always a really complicated topic in the cancer world. And I think what is super interesting, and there's a great example of it in colon cancer risk reduction literature, is that there seems to be an association with improving your risk if you take in the key vitamins and minerals through food versus through supplements. So folic acid is the supplement, and folate is the food version that you get when you eat food versus a pill. And they have shown that if you have an increased intake of folate in your diet from some of these folate-rich foods like spinach, asparagus, broccoli, papaya, and lentils, you can actually decrease your risk of colon cancer. But supplementation with a high dose of folic acid is actually associated with a higher risk of 3 or more adenomas or cancers. So I tend to have a strong bias towards recommending that people try and get their nutrients from food products as opposed to supplements in general. Now, calcium is a bit of an exception. There is it's a little bit controversial, but a relatively strong recommendation to make sure that you're getting at least 1,400 milligrams a day of calcium, because that is associated with a 20% reduction in risk of adenomas or polyps, which are the precancerous things. That seems to benefit mostly people that are in the normal or overweight range as opposed to the obese range, but I still think it's probably a very reasonable thing to consider. And they haven't proven that it decreases your risk of invasive cancer, but we do believe that most invasive cancers start as polyps. So I tend to fall down on the side of considering a calcium supplement if you're not able to get enough of it in your diet. Vitamin D was all the rage about a decade ago because we noticed a lot of association between low vitamin D levels and a higher risk of many cancers, including colon cancer, and worse outcomes. But we've never been able to show that supplementation with vitamin D is helpful. So that is definitely a talk to your primary care doc about your individual risks and benefits for that particular supplement. The other thing that I think is interesting about looking for the, how much folate or how much calcium is in food sources is that it's all really easily available out there on the internet. It's one of the things the internet is good for, is finding that sort of information and these kind of graphics that give you an idea of how much you need to take in to get all of your nutrients in your food. There is some support for magnesium supplementation or increasing magnesium in your diet. Again, my bias is towards doing it with increased dietary intake. And these are some magnesium-rich foods up in the corner. You can see dark chocolate is my personal favorite source of magnesium, but we also have avocados, bananas, almonds, oats, all good things to be considering taking into your diet. Fish oil is another controversial subject in terms of whether supplementation helps, but there is indication that increasing your fatty fish oil containing fish in your diet is helpful in terms of reducing your risk. So a lot of information, and we are moving into the aspirin world. Aspirin is associated with a reduction in the risk of developing polyps and a reduction in the risk of invasive cancer, but we don't know the optimal dose. There's some evidence saying that if you weigh over 154 pounds, you should take a full-size aspirin as opposed to a baby aspirin. And of course, aspirin does have some blood thinning effects. So it's another thing to consider discussing with your primary care physician. And we also have noticed some interesting correlations between how aspirin benefits patients based on their sex and, as I mentioned, their weight. But aspirin, I think, is a reasonable thing to consider for risk reduction. So bottom line, this is your to-do list. I do recommend getting screened, and we're going to go on to that next. For exercise, since we don't know the dose and the type that is most effective, I say do 30. My recommendation for my patients and what I try to do myself with varying success is get 30 minutes a day, at least 5 days a week, of some form of exercise where you break a sweat or it's hard to talk or you get your heart rate up a little bit. So it's a very concrete prescription, and it doesn't have to be 30 minutes all at once. You can do it in 5-minute chunks if that's how you need to do it. So I think it is something that's achievable for most of us, and it's important for many reasons, not the least of which is trying to reduce your risk of cancer. Getting 30 grams of fiber a day is something that is to be worked up to. I would say that's a stretch goal if you're eating the average American diet, but it is something that you can think about, especially during Nutrition Month and going forward from Nutrition Month. Think about adding a little bit of fiber to your current diet till you get to that point where you're getting 30 grams a day, and I think your body will thank you. More fruits and vegetables than red meat. I think most of us have seen that description of a plate where, at least half or 2/3 of the plate is fruits and vegetables, and then the other part of the plate is either meat or carbohydrates, something on that. And I think that's a really good recommendation, specifically for colon health as well. As far as supplementation with aspirin, calcium, vitamin D, or magnesium, I do recommend talking to your primary care doc because there are some risks and benefits there that are a little complicated, but certainly we can all be mindful of getting more calcium, vitamin D, and magnesium into our diets. In terms of the try not to do list, obviously smoke and tobacco use of any kind are associated with so many bad things that if there's anyone on the call who's struggling with that, please reach out. There are a lot of resources to help you quit, and it is hard to quit, but it can be done. Most people, last time I looked at this, actually have to attempt to quit smoking or using tobacco products of any kind 7 times before they succeed in the long term. So if you've done it once and failed, start again, keep trying until you're able to quit. Hopefully no one on this call has that, but just in case. I think that the data does support trying to avoid a weight gain in that 18 to 50 years of age range. And I think that the statistics that I read over the last year is that a lot of people gained about 2 pounds a month during the COVID pandemic. So yikes, that's been a hard time for a lot of reasons. But if you're able to decrease weight gain or lose weight if possible, I think that might be beneficial. I recommend you do not eat bacon or other processed meats, bologna, fermented stuff, cured meat products every day, and try to keep to less than 1 alcoholic drink a day on average. And then also equally important, it is very easy for busy people to ignore symptoms. And I would strongly like to recommend that you do not do that. We will go over some of the symptoms that could be of concern in a little bit. But I think the whole point of this Live Well program is to really try to help each other and support each other in taking care of ourselves. And a big important component of that is not ignoring your symptoms from your body. In Oklahoma for colon cancer screening, we're not doing great. The map that you see on the left actually shows us in Wyoming, and we have the lowest incidence of any colon cancer screening. This is on a county by county basis. So there's some other states that are also not doing very well, but we are consistently in the bottom of the pile in terms of our screening rates for any colon cancer based on the recommendations from the USPSTF, or United States Preventative Services Task Forces. And then this map over on the right is to show you that screening really does work. So this is the rate of new diagnoses, and you can see all the areas that have high screening rates in dark blue over here have low diagnosis rates. And that's just to really drive home the point that we can actually prevent this cancer by doing the screening and by taking out polyps before they have a chance to become a diagnosis of colon cancer. So I am a bit of an evangelist for screening. Again, to nail home the why, most colorectal cancers develop from polyps and are therefore preventable. It's not 100%, but certainly we can decrease that risk a lot. And we've been able to do that by 53%. We've decreased mortality from colon cancer by 53% from the 70s till now. And most of that is due to increased screening and prevention, in addition to some of our better treatments. But screening and prevention make a huge difference for this disease, and it's a hard sell for a lot of people. The screening recommendations, these are the symptoms that I mentioned. So if you're on this call and no matter what age you are, you're having any of these symptoms, blood in your stool, dark tarry stools, changes in your stool caliber, or persistent unexplained abdominal pain that goes on for more than a few days, these are things that you need to get checked out. They're not something to ignore. Now, if you're an average risk person with none of these concerning symptoms, then the recommendation for the American Cancer Society is now to start screening at age 45, and that is actually a decrease. It used to be 50, which is what many of the other societies are recommending. Did I hear someone wanting to ask a question? Nope. Okay. Jump in if you do. So there is a little bit of a difference between what many other sort of guidelines making societies and the Cancer Society are recommending. I personally think that the American Cancer Society made this recommendation change to age 45 for very, very good reasons and very solid data. So I recommend that people start their screening at age 45 as opposed to 50. Having said that, you know, a lot of people are late on either category. So I think start thinking about it at 45 and try to get it done if you can. In terms of who is at high risk for colon cancer, I said that was the average risk recommendations, but for people that are at elevated risk, these are people that have had colorectal cancer themselves or a polyp themselves. If that's the case, then you have about a 1.4 times higher risk of having another one than the general population. So I'm pretty sure that everybody would have guessed that. If you've had inflammatory bowel disease like ulcerative colitis or Crohn's disease, the recommendation is for you to start screening 8 years after the initial diagnosis. And there are some people who've had abdominal radiation for a childhood cancer, and that increases the risk considerably by about 11-fold. So it's significant. And the recommendation is to start 10 years after the radiation treatment was done or at age 35, whichever is younger. Then last but not least, anyone with a family member with colon cancer or polyps, trying to figure out how much your risk is elevated depends a little bit on who the relative was when they were diagnosed and what they were diagnosed with. And you can see the increased relative risk here. So this is a person with no family history of colon cancer. Are you guys, I'm assuming you can see my mouse, so I think it has been working in the past. So this lowest bar is patients with no family history of colon cancer or adenomas, and that's the risk of 1. And then somebody who's had a first-degree relative, so a father, a mother, a sister, those, if they have had a first-degree relative with colon cancer, the risk goes up to about 2.25 higher. And it goes all the way up to 4.25 higher if you've had one relative with colon cancer, more than one relative with colon cancer, or if you have a relative who was diagnosed before 45. So this is where your family history is actually pretty key. And I recommend that people use any family gathering time, even if it's a Zoom call on Christmas or Thanksgiving or for a birthday, to make sure that you kind of get updates on your family's history, because it actually will really affect your risk and when you should start screening. If you do have an increased risk because of a relative, you want to start 10 years younger than the age at diagnosis of the relative. So if your father had colon cancer at 80, then you start at the normal age. But if your father had colon cancer at 40, you need to start your screening at 30 years of age. There are a lot of different screening tests. I mentioned it can be a hard sell, especially sometimes for guys in our culture, to recommend that they get a colonoscopy, but it is incredibly important to do one of these screening tests. The options kind of divide into things that are looking at chemicals in your stool versus direct visualization and ways that we can actually get a direct look at the inside lining of your colon. And then there's a few things that are no longer recommended that used to be recommended for screening. Those include things like a barium enema, which is where they give you contrast up your rectum and then take an x-ray. That hasn't been found to be as effective. DRE stands for digital rectal exam. And obviously we don't really get much of we can't get very far into your colon from the rectum with a hand. So that's not terribly effective. And then there is a single office-based guaiac fecal occult blood test. That's where the doctor does a rectal exam, puts it on a card, and does it one time. And that has also not been found to be effective. So the ones on the left of the screen are the ones that you want to consider for yourself. And they all have different pros and cons. I put the stool-based tests up at the top of this table, and then the direct visualization tests down lower. And just to kind of give you a brief summary, if you're doing a standard looking for blood of any kind test, which is that fecal occult blood test or guaiac test, that has to be done annually. So you start at 45, you do it at 45, 46, 47, et cetera. It doesn't require any prep, so that's a big pro, but it also may not detect the polyp. So it's a little bit better at detecting an actual invasive cancer, which means that you've got the diagnosis that we were trying to prevent. It also can be fooled by some things in our diet that the FIT test or the fecal immunochemical test cannot be fooled by. So the main difference between these tests, they're both looking at substances within the stool, but the FIT test is actually set up to detect human blood loss as opposed to the steak that you had the night before. So the FIT test can be done annually as well, does not require a prep, has increased accuracy for because it's specific to human blood loss, and it can be done in a single specimen without dietary restrictions. But again, it may not detect those precancerous lesions that make us want to prevent, that we would like to be able to detect to prevent cancer. The FIT DNA test is the Cologuard test that has been all over. I don't know about you guys, but I see it every time I turn on a TV or a streaming service. This is a FIT test, but then they also have combined it with looking for some DNA that actually has mutations that are commonly found in colon cancers. And that combination increases the ability to detect cancers, but it also increases the false positive rate. So that test is actually associated with a 13% chance of having a false positive. So it is effective, but you may end up with a result that scares you and drives you to go get a colonoscopy anyway, and then find out that thankfully you don't have a cancer. That has to be done every 3 years. It says 1 to 3 years, but the most common recommendation is 3 years for the Cologuard test. And then getting down to the direct visualization, a colonoscopy, if it's done well, can be done once every 10 years, as long as you don't have polyps. If you do have polyps, the gastroenterologist will give you a shorter screening interval for that. The advantage of this test is that it can see the entire length of your colon. And if there's any polyps, they can be removed while they're actually doing the colonoscopy. The downsides is it requires the prep that I'm sure people can speak about. It is a significant it's a prep that drives you to the toilet for a good set of hours before the procedure. So it is not the easiest or most fun thing to do. It also, for most people, requires sedation. I've had a few people go through it without sedation, but it's not something I would recommend. They felt very strongly that that's how they wanted to do it. So it can be done, but probably not what I would recommend. And it is associated with a risk because it's an invasive procedure. And the main risk that we worry about is the risk of perforation of the colon, which could result in emergency surgery. That is a low risk. It's probably less than 1 in 100 on average. And getting a colonoscopy can actually reduce your risk of death from colon cancer by about 53 to 68% in people who have adenomas. And if you have a negative colonoscopy and you're up to date on your screening, you only have a 2.9% risk of colon cancer, which is a lot lower than if you had done no screening. Flexible sigmoidoscopy is essentially a short colonoscopy. It's where the scope only goes up to the bottom, from the bottom to the third of your colon. So we're missing 2/3 of the colon, and that's why it has to be done more frequently. But it also can be combined with FIT testing, and in combination with FIT testing annually and a flexible sigmoidoscopy every 5 years, it has been shown to be pretty effective in terms of reducing your risk. The upside of this is, again, if they see a polyp in that lower third of your colon, they can take it out. It doesn't require sedation in most cases as compared to a colonoscopy, which does in most cases. And it has a lower risk for perforation than colonoscopy. The downsides are it still requires that prep, and you're not able to see the right side of the colon, which is the part of the colon actually that we're seeing an increased diagnosis of colon cancer in women. It does reduce mortality, but colonoscopy is probably a little bit better. And I think most people nowadays, actually, if they are able to, would choose a colonoscopy over a flexible sigmoidoscopy. CT colonography is falling out of favor. That's actually a CT scan that is very specifically done in terms of the prep. They do have to give you some CO2 to kind of distend the colon, and then they put you through a CT scanner, and then they actually they sort of put together all the images a computer does that allow us to look at the inside of the colon in a way that we can't with a normal CT scan. The pro of it is it doesn't require sedation, but unfortunately for us to be able to see things adequately, it does still require the prep. And if we see a polyp, we can't take it out because it's just a CT scan. We're not actually there. Insurance actually doesn't cover CT colonography in many cases, so that's another barrier, but it is a possibility for someone who just can't really stomach the idea of a colonoscopy. And then last but not least, you can actually now take a pill with a little battery-powered camera, which transmits images, and that actually can go through your entire GI tract from the mouth all the way down. And that is certainly a reasonable option. A prep is generally recommended so that the wall of the colon isn't hidden by stool. That could hide a polyp for us. But it also doesn't allow us to do that immediate polypectomy. And very rarely that capsule can actually get stuck in your GI tract. And I'm not going to make the Suez Canal joke, but it is a possibility that you need to know about. So those are all of the pros and the cons of the screening, and I'm definitely hoping that somebody will have some questions on those at the end, because the most important thing I can say about screening is that of all of these different options, whichever one you think is right for you, please, please, please do it. Colon cancer is preventable in most cases, and it's always heartbreaking when you see somebody who is diagnosed with an advanced rectal cancer in their late 50s, and we know that it could have been prevented if they were able to get screening. So that is my strongest recommendation from this talk. If you do get diagnosed with colon cancer, the treatment usually involves a combination of surgery and chemotherapy, but the first step is always for us to see how far it's gone within your body or to stage it. And that's most commonly done with a CT scan of your chest, abdomen, and pelvis. And if it's a rectal cancer, we'll add a pelvic MRI because that gives us more detail about the anatomy that we need to know. Surgery is the most common first course treatment unless the disease has already spread. But even if the disease has already spread, there are times where surgery is actually an option and can be curative. So I always put that out there so that people know to consider it and to talk to their doctors about options, even if it is stage 4. This is just a little schematic of the different staging in the earlier stages, and I'll show you survival for these in a second, but in the earlier stages, the cancer hasn't gone through the lining of the colon itself, so it's very much contained, and it's something that we can take care of with surgery. A little bit more advanced by stage 3, it's gotten to some of the lymph nodes in the area, and those also commonly come out with surgery when we're doing it for colon cancer. And then in stage 4, unfortunately, it's gotten to distant organs like the liver or the lungs, or in some cases, ovaries and other parts of the body. Survival is amazing for this disease when compared to other types of cancers like pancreas cancer, for example. So, 90% 5-year chance of surviving the disease if we catch it early, which is another reason that screening is so important. Even if we miss the polyp and we get it, but we get an early diagnosis of cancer, 90% of those people are going to be just fine. And there are some also, I want to mention, long-term survivors, even from stage 4 disease. So this is not something to ignore. If you are having symptoms, this is something we can most likely help out quite a bit. And I always put this in there to remind everybody, this patient is a patient of mine who was diagnosed with stage 4 colon cancer at age 48. It's now been 13 years, and NED means no evidence of disease. And she lets me show this picture because she always wants to communicate how much hope there is in this field. She's done great. When I met her, her youngest daughter was 12. None of her kids were married, and now 2 of the 3 kids are married, and she's had 3 grandchildren and gotten herself a bachelor's degree. So there is hope. Having said that, we'd like to prevent the late stage diagnosis so that we can do better. And that is the end of the talk, and these are my cats. I would love to take any questions, and I'll stop sharing my screen. I don't see any hands raised. Is everybody excited? Go get screened.
Hi, Dr. Morris. I have a question.
Yes,
Can you hear
sir.
me? Yeah, I have a question. I know there's more and more people, younger people, suffer from colon cancer. So what's your suggestion for those people for screening, or some suggestion? Yeah.
Yeah, thank you for bringing that up. I mentioned it just very briefly in the beginning, but for some reason, despite the fact that our incidence of colon cancer is going down in general, the incidence amongst young people is actually on the rise, and we do not know why. So if there is no family history and no known risk factors and a person is asymptomatic, we think that the risks of screening outweigh the benefit of screening. But if anybody has a significant family history or any symptoms at all of the symptoms that I mentioned, even if you're in your 30s or 20s, and we've had patients diagnosed at age 21 with very advanced colon cancer. So I think the best recommendation I can give is to not ignore symptoms, even if you're young and you just assume, oh, it's something else. As far as why we're seeing this increased incidence in young people, there's a lot of theories and not a lot of data. I'm hoping that we will get a handle on it, because then we could do something about it. There are many people that think that it is related to the changes in our diets, but I wish I had an answer for you. So hopefully the message is, if you have symptoms, even if you're young, please do not ignore them.
Okay, thank you.
My question is if somebody's had a history of some chronic constipation issues, or are they at higher risk developing the cancer?
Great question. Actually, I forget that I'm on Zoom, so everyone heard that question. Oh, I miss in-person things. So the question about constipation, chronic constipation being a risk factor, there's not a lot of support for that as a known risk factor. Having said that, I think that there's some things that could associate with it. So the chronic constipation could be due to maybe low fiber intake. It could also just be the way that your body's made, but the short answer to the question is there's no known increased risk for patients with chronic constipation. Having said that, it's not something I would, ignore. And if it's really causing a lot of symptoms in your life, I would consider seeing a gastroenterologist to discuss, because there actually are a lot of things now that we have available to help with that as well.
Hi, I have another question as well. And I was just a couple of minutes late, so if you presented this, I'm sorry. Any data for other countries and their rate or incidence of colon cancer versus the United States?
Yes, actually, there's some beautiful data that's made by the International Association for Cancer Research in Cancer, the IARC. So it's IARC, and you can actually look at cancer incidence, at least what we know for what countries are reporting for many different cancers and all across the country with different maps. It's really a phenomenal site. So if you just search for Global Can, GLOBOCAN or IARC, you'll get that data yourself. Specific to colon cancer, it does seem to be a disease associated with Western diets. So as people become more industrialized in their country, we do see rates of colon cancer rise. So there's definitely a diet and lifestyle link. We haven't been able to really tease out how strong that link is. But I would recommend that GloboCan website is really fascinating, and you can literally pull up multiple different maps with a lot of data from all over the world. Did that get to your question?
Yes, thank you very much. I appreciate those resources.
Hi, Dr. Morris. This was a great presentation, and I had a question for you. Do you find it difficult to get insurance companies to get on board with younger patients, where there's evidence that they need to have maybe a colonoscopy, and, you find payers saying, no? I'm glad to see that the society had lowered the age to 45. But, just as an employee here, I saw something came across from Blue Cross Blue Shield that said recommendation is 50. And I thought, but they just lowered it to 45. So do you have to spend a lot of time trying to appeal authorization to get it for younger folks?
Yeah, sometimes you do have to definitely, I think you can appeal. So it is difficult because the United States Preventive Services Task Force hasn't lowered the age recommendation yet. There are societies, the American Cancer Society does carry a lot of weight, so you certainly can appeal a denial if you choose to start screening at 45. If you have symptoms, though, that's a different ballgame. So anyone who has noticed blood in their stool or change in their stool caliber, no matter what their age is, it would be difficult for an insurance company to forbid that. And we do spend a lot of time fighting with them, truth be told.
Yeah. Thank you.
Thank you for posting that link, Kaylee. That is one of my favorite sites ever. I just think it's amazing to be able to see what other countries are doing to fight cancer. Any other questions? Everybody's going to get screened if they haven't been. The best evangelist for screening that I ever had in my career was I was treating the patients. My patient was actually the guy's wife, and she had colon cancer, and I was treating her, and I asked him if he had been screened. He was 52, And he was like, yeah, no. And I kind of twisted his arm a little bit, and he had 15 premalignant polyps. And so after that, he was like telling all of his friends, which I think is actually really important. So telling your friends that you can get through the screening, it's not that bad, is actually an important thing that will help your communities, because it's a hard sell sometimes.
Well, if we don't have any more questions, I'll go ahead and wrap it up. Dr. Morris, we appreciate your time. This was a very informative presentation. I learned quite a bit. I was kind of nerding out in the background about it. Lindsay probably was too as well. So we greatly appreciate your time. Thank you for helping raise awareness for this. And I hope that all of our participants go out and be little proactive awareness members in the community as well. If you are a Live Well OU member, you can redeem this colorectal workshop for Live Well OU points in the wellness portal under physical wellness as a physical wellness workshop. So don't forget, you can just go in there, enter that in, enter the date and the workshop name, and you'll be good to go. Once again, thank you for joining us, and I hope you have a wonderful day.